Hello, good evening, good afternoon, good morning to you, wherever you are tuning in from. Welcome to the first of the 2023 Facebook Neurology for Vets Live Journal Club webinars. These webinars are sponsored by Hallmark Advanced Veterinary Imaging. We're very grateful for this. Thank you very much, Hallmark. If you have not joined us before for one of these webinars, this is a very informal format where we invite young stars of the veterinary profession to share with us their recent neuroimaging publications. And today we are very pleased to welcome Dr. Guillaume Dutil. Did I do okay there? Was that okay?
Yeah, perfect.
But no, not perfect. Usually I apologize. I'm not very good at people's names, but I'll have another go. Dr. Guillaume Dutil. So welcome, Dr. Dutil graduated from veterinary school at the University of Lyon in France in 2016, where he also did a rotating small animal internship and a doctoral thesis focused on anticonvulsant toxicity in dogs and cats. Guillaume completed a specialized internship in neurology at the University of Bern in Switzerland. So hello to all of our friends there. And that was done in 2018, and then followed by a residency in neurology until 2022. And at the same time, Dr. Dutil worked part-time, not enough apparently to do, so worked part-time in a veterinary practice in Nantes called Atlantia, and also at the veterinary school of Nantes in France, where he currently works full-time. Today, Dr. Dutil will discuss his most recent publication, investigating the MRI characteristics of otitis interna in cats with and without meningeal enhancement. So thank you very much, Guillaume, for being with us today. And I'm going to hand the show over to you.
Thank you, Simon. Thank you very much for the invitation. I'm really happy to be here with you. And also thank you, Laurent, for that, and Hallmark. So hi everybody, I will present you today this study that we published just in January in the GFMS about otitis media interna with or without polyps in cats and their association with meningeal enhancement on post-contrast MRI, CSF findings, and also clinician treatment choice and outcome. So for the background, you all know that otitis media interna is a common inflammatory disorder that we can find in cats, and sometimes they are associated with a polyp, and otitis interna is leading to vestibular disease. You also see sometime on MRI meningeal enhancement. This findings is unclear about the clinical and therapeutical implication that we can have for this in MRI for any disease. And generally, the recommendation or indication that you can have from a diagnostic imaging people is to tap the animal, but sometimes clinician does it or sometimes they don't. So for this study, basically, it started when we get a case of otitis media interna. You can imagine if there is a polyp or not. And I was wondering myself, if I don't see any meningeal enhancement, do I have to tap it or not? And that was really the question that I asked myself. So I asked also my mentors in Bern, and I could get either yes or either no. So I was like, okay, there is nothing clear about that. But also when there is meningeal enhancement, does it change something? Do we have to tap them more or not? So that's why we did this study at the beginning. So the aims was first to describe if there were any association between meningeal enhancement and CSF. That was the main topic at the beginning. And then we started to discuss about maybe there is also an association between the bacteriology culture results and meningeal enhancement, or the same for the CSF, abnormal CSF findings. And also if these bacteriology results can lead to a change or adaptation of the therapy for the cats from the clinician. So the hypothesis were that meningeal enhancement is associated with abnormal CSF findings, we also thought that either a meningeal enhancement or a CSF abnormality can lead to a more often positive bacteriological culture, or bacteriology results can also lead to an adaptation of the therapy by the clinician. So for the material and methods that we get, it was a retrospective study. We just collected cases from 2010 to 2020. We asked several centers to help us. So we were 6 in the study, and I would like to thank all the co-authors of the study that helped me a lot for this article, and also for the cases that they share with us. Then for the inclusion criteria that we used, it was cats. Then we looked for cases that had a peripheral vestibular neurolocalization. We also look for cases from MRI that were compatible with otitis media-interna with or without polyp. And of course, that they should have also post-contrast sequences. We looked also for cases that had CSF analysis. No intraaxial lesion, so that was also a criteria that was really important for this study. And then we collected the signalement, the history, treatment, if it was prior and also after the referral, which side were the vestibular syndrome. Then we collected the MRI images and reports, the CSF findings, the bacteriology results from the affected ear, and then we looked also at the outcome. So for the results, for the signalement and history, we collected 58 cats. 32 of them were domestic short hair. That was really the main breed. For the sex ratio, you can see in blue there is male, and in pink it's female, and in pale blue and pink it's neutral patients. So it's quite balanced in our population. The mean age was 6.9 years, and also you can see that there were really young cats, but also old cats were represented. And then for these cases, there were 37 acute cases and 21 chronic, and we use these chronic cases if the clinical signs were lasting for more than 2 weeks. From these cases, 32 receive a medical treatment before the presentation, so before the referring. You can see all the different therapies. So 9 of them just receive antimicrobial therapy, 9 with corticosteroids also, and 8 with NSAID. 2 receive both corticosteroids and NSAIDs and also antimicrobials. 5 only corticosteroids and 1 only NSAIDs. From these values, there was no really a consequence on the time to presentation, meaning that even if they get this therapy, there was not really a difference before they come to the referral center. For the diagnosis that we get, there were 13 polyps. 6 were diagnosed by histology after surgery. 2 were visualized during bular osteotomy, 2 during myringotomy, and 2 were only suspected by MRI. So all of them had MRI suspicion, of course, but then there were more or less more steps to confirm that it could be a polyp. And the same for otitis media-interna. So 45 cases were suspected of otitis media-interna, 3 with histology, 3 only with visualization during bular osteotomy, 26 from myringotomy, and I think 12 during MRI. I cannot really see. I will show 13. Sorry, were only suspected with the MRI. So just to show you an example of cases. So this case was an otitis media-interna without meningeal enhancement. So you can appreciate here it's T1 pre-contrast and T1 post-contrast, and you can see so the bulla here with this T1 hyperintensity, and then you can compare pre and post contrast images, and you cannot really see this meningeal enhancement. And on this case, it was a bilateral one, and you can really appreciate here that there is a strong meningeal enhancement here, and also enhancement of the vestibulocochlear and facial nerve on these sides. Then we look at the results between the meningeal enhancement and the CSF. So we get 26 cases with meningeal enhancement. 9 of them had an abnormal CSF findings, meaning cell count was abnormal, or there was albuminocytologic dissociation. So it's both considered abnormal. And then 17 of them had a normal CSF findings. So it means that 65% of the cases with meningeal enhancement had a normal CSF finding. The same, we get 32 cases without meningeal enhancement. 10 of them had an abnormal CSF and 22 had a normal CSF finding. So 31% of the cases without meningeal enhancement had an abnormal CSF result. So then I use the table from the article, so just to show you a bit more clearly, because here you can see that there is acute and chronic cases, and you get either CSF that was abnormal with the CSF plus or normal with the CSF minus, and also for meningeal enhancement, if it's present, it's with the plus, and absent with the minus. And just to make it clearer for you, I just remove the part of the CSF, and then you can get, for example, for meningeal enhancement, when it's acute or chronic, and you can see that this was statistically significant. So cases with chronic presentation were more likely to get meningeal enhancement. No, sorry, I just mixed it up. It was with the CSF, sorry. So with the CSF, it's the wrong p-value, sorry. So with the CSF, you can see here, it's really clear that you can get, with chronic cases, really less frequently an abnormal CSF compared to the cases with acute presentation, that is not 50-50, but it's really close from the findings. So this was the significant p-value. But then for the meningeal enhancement, that was not significant. But here you can see also these numbers that were quite similar. Then we also looked at the treatment before the referral, and therefore before the MRI, and we looked if there was any association with the findings and the anti-inflammatory drugs. So when they receive anti-inflammatory drugs, it's on the left side here, and when they didn't, it's on the right side. And you can see also, it's again with CSF and meningeal enhancement, but the cases with CSF, abnormal CSF and abnormal meningeal enhancement that receive anti-inflammatory drugs, there were 3 cases, and you can see that even with this anti-inflammatory, they could also get normal CSF findings and no meningeal enhancement also. And these values were not statistically significant. Then we also looked at the presence, if the polyp was present or not. So again, it's the same presentation with CSF and meningeal enhancement. And also for this value of polyp or absent polyp, there were it was not statistically significant with our cases. So from our first hypothesis, we can say that the meningeal enhancement that we can see on MRI is not related to more abnormal CSF findings. And we can also add that we can find abnormal CSF even if there is no meningeal enhancement. So that was really something that we were not expecting. If we discuss a bit with what was previously described in the literature, we looked basically on cases with intraaxial lesion, because there was not really a presentation of cases without intraaxial lesion. And you can see that when there is a lesion, intraaxial lesion, you are really more likely to get abnormal CSF results. And if we look just in one article that was doing the difference between acute and chronic cases, and there they also had a difference between these acute, subacute cases and chronic cases. So for them, it was not statistically significant because there was not a lot of cases, but that was the case for from intraaxial lesion also. So maybe that's something important to remind. Then we look at bacterial culture from these cases. So 45 cases had bacterial culture, 13 from bulla osteotomy, 28 for myringotomy, and only 4 from external ear canal directly. It was negative in 33 cases, and you can directly see that if they receive antimicrobial therapy before sampling, it was still 39% of the cases that were negative, and it was positive for 12 cases, and 7 of them, so nearly 60%, also receive antimicrobial therapy before sampling. So that's something also important to remind. I took again the table from the article. So you can see here with the meningeal enhancement, again, when it's present or absent, and with the culture, so if it's positive or negative with all sampling, and also here with the CSF, and you can see that that's also not statistically significant, sorry. So yeah, that's a bit more details about all the way that the bacteriology was done, but yeah, we don't, we just mix them all together because we don't have any enough cases to do it just with one site of culture. Then, something interesting is that if there was no meningeal enhancement plus an unremarkable CSF, 12% of the cases had a positive bacterial culture. So only 12% if you don't have any meningeal enhancement or CSF abnormalities. It's quite low, and you can maybe expect that the bacteriology results would be negative if it's the case. So that was not significant. I will show you that just after, but that's something also that was interesting as a finding. And there was no difference between acute or chronic cases for the results of bacteriology compared to the CSF results previously. So an abnormal meningeal enhancement or CSF result is not a good indicator for bacteriology results with our cases. So as I told you, the first information is maybe interesting for the practice. But then we also draw something, and you will see afterwards with the outcome and the therapy. But it's really remind us that we probably need to alter the antimicrobial treatment if the culture results are negative. So that's not something that would be unlikely. So we really have to remind that. And something that was not discussed in the article, it's maybe good to perform this bacteriology culture even if the cat already received antibiotics. That's maybe something for me. I have to say, probably I would say, well, he already received antimicrobial, so I'm not sure that I should send bacteriology culture, but definitely with our cases, that's something that we should do. So for the antimicrobial therapy, it was started in 26 cases before the referral, and 28 it just started after the referral. I also don't go into details with the first and second line antibiotics. It's in the article, but we didn't discuss so much this aspect here. And we can see the choice now of the therapy So meaning you get the MRI and the CSF results and the bacteriology culture, and you look what was placed as therapy from the clinician. So that's the interesting part also for us. And you can see that for meningeal enhancement, the anti-inflammatory drugs, that was not really different based on the meningeal enhancement. From the CSF results, here there is a tendency, it's not significant. The only thing that was significant, if you want to do a bit of statistic, is if we just consider corticosteroids or something else, meaning NSAIDs or nothing. So then you can get these values, and this was statistically significant. But we didn't put that on the article because then you can do statistics from whatever you want. So just for your information, that was something maybe that could have be important also. And then for the culture also, that was not statistically significant, the use of anti-inflammatory drugs. Then we looked at the length of therapy, and you can see here when it was a positive or negative, then you can just look at the weeks under therapy. So this was different from these cases. When it's negative, there is a trend to be a bit shorter, but that was not statistically significant for the three, the culture, the CSF, and the meningeal enhancement results. So we said that it could change the therapy strategy, but that was not significant. Then we look at the outcome, and for the outcome, we can get, we define the good outcome as an improvement of clinical signs. And so 2 cases had an euthanasia several months after the diagnosis, but unrelated to the disease. For example, one was a carcinoma, so definitely nothing related to the otitis. And poor outcome were defined as a lack of improvement or an euthanasia from these patients. And again, here you can see that there is not really something significant from this result, but we don't get a lot of cases. So what we can maybe say is that if there is meningeal enhancements, maybe they tend to get poorer outcome. Meaning that here it's approximately 25% of the cases, and here it's only 12, but definitely there is probably not enough cases to say something like that. The cases with bulla osteotomy had a really good outcome, and then that were medically managed had a bit less good outcome. There was no euthanized patient in the bulla osteotomy group, and with the medical management there were 4, and also 1 that was intermittent and was euthanized really long time after for seizure-like episodes. So we don't really know if it was something related or not to the otitis. We consider it as related to the otitis. So to conclude, I will just draw some interesting findings that we get. So meningeal enhancement was present in 45% of the cases. So that's nearly the half of them. 47% of the cases showed a discrepancy between meningeal enhancement and CSF, so that's really something important. The CSF results may influence the anti-inflammatory drugs choice, but does not appear to change significantly antimicrobial therapy duration. So that's also something important to know. And chronic cases had fewer abnormal CSF findings. And again, it's not discussed in the article, but I just add that's positive bacterial culture, even if under microbials, could be a good thing to do. The limitation, of course, it was a retrospective study. There was an exclusion of cases, the one without MRI, so just CT for otitis. Sometimes it's also good to do only a CT, so they were excluded. Also the cases that did not get CSF tap, and that's also maybe common from some neurologists, so definitely that's a limitation. Also the one with intraaxial lesion were removed from the study. And from the MRI, we discussed a lot about reviewing all of them and doing another report, or let's say just blinded the diagnostic imaging people and say, well, do you see any meningeal enhancement or not? But because the reports were already performed by diplomates, then we said we could trust them. Thanks for your attention. And then if you have any question, I'm happy to answer to them.
Thank you very much, Guillaume, for this presentation. To me, this presentation is exactly what I enjoy, which is, you know, as neurologists, the way we train, we tend to do things really like by habitus, you know, so we always told you need to do this, this and that without challenging it. And I like any study that challenge, you know, what we tend to do. And I think that's a good example, you know, whether or not we should do CSF on this case and does it change anything? I think a similar example would be dog with, you know, the so-called generalized tremor, and whether or not doing CSF influence what we're going to do. And in this dog, if you know there is no known, you know, toxin exposure, if you rule out metabolic disease, then whether or not the CSF through an inflammatory process doesn't seem to me to change what you're going to do, because they end up being immunosuppressed. So that's, you know, similar concept, and I really like, you know, this kind of study like you did. A few questions. One that I wanted to ask you before I put the question from the audience: did any of these patients had culture on the CSF or not?
Yes, only one, and it was positive. But for example, in Bern, we are not really sending so much CSF, or generally they get back negative. So we are a bit bored to send them, and we just say, well, probably will be negative, so we are not really sending them all the time anymore. But yeah, only one had a positive CSF.
Well, that's very rare as well. And in terms of seeing bacteria having a negative culture, but seeing intracellular bacteria on the CSF, was there any with that as well? Or?
So I don't know. We didn't look for that specifically. So I don't know from these cases if there were some with intracellular bacteria and culture, but I have to say that I get some of these cases from the study, and I remember one of them that we see with bacteria inside cells, and we sent bacteriology and it was negative. So definitely that's possible to get negative results even if you see intracellular bacteria.
And the last one, it would be, does any of these cats have some, I mean, CNS sign, long track sign, or they all had sign that would be consistent with the peripheral vestibular involvement?
So all were peripheral. That was one criteria. So because I just based this criteria on the paper that I said that, well, when you think you get something central, generally it's central, and when you think that something is peripheral, it could still be central, but generally when you think it's central, it's rarely peripheral. So we just took clinically the one that was that were peripheral only, and then we excluded the one that get intraaxial lesion on MRI. So basically, none were central. Yeah.
Very good. We got a question from Emil that Simon and I know very well. Thank you for your great presentation. Did you look at whether treatment with systemic corticosteroid had an effect on time from onset of sign to presentation to the referral center in Otitis Media-Interna?
So we looked at that. It's my slide when I said, well, there was different therapy. So we didn't look specifically for corticosteroids without looking at antibiotics or NSAIDs. But for these groups, and you can see that there was not a lot of cases per group, but when we looked at that, there was not really an influence of time to presentation. No. And all the corticosteroids dosage were anti-inflammatory. just also if it's something that for you can make sense. So there were none with high dose of corticosteroids that's really worsened quickly.
I think some people may be wondering, will you suggest using anti-inflammatory corticosteroid in this case in addition to antibiotic treatment and surgery if there is meningeal enhancement?
Yeah. So personally, now I'm really more tend to use corticosteroids than NSAID, and I discuss also a lot with dermatologists because they also see a lot of cases like that, and they like to give, or at least some of them like to give corticosteroids. So I have to say now I would more go for corticosteroids in such etiology. Yeah, definitely.
Okay, at anti-inflammatory dosage, I presume.
Yeah, sure. Yeah.
Good. Another question from Joanne. To clarify some doubt about the study, I would like to know your opinion in choosing corticosteroid versus NSAID. We kind of, cover that to some degree. And if I'm correct, you will prefer to use. But can I clarify? Will you choose corticosteroid whether or not there is CSF or meningeal enhancement, or if there is only Otitis Media-Interna?
Yeah,
you stay away from steroid?
Yeah, I think in all cases that could be good, particularly if the otitis media-interna is severe, even if there is nothing in the CSF and no meningeal enhancement. I would say for me, or to me, this otitis needs a bit of anti-inflammatory drugs, so I would give anyway corticosteroids. Yeah.
So that was my next question for our listener. How long would you recommend to use them?
Yeah, so that's a good question. So what I do now, it's more giving them for 3 weeks with reducing dosage every week. So that's the plan that I use actually, but I don't know if it's the right one. Huh? It's more like now I really tend to use this protocol. I think it's okay.
And will you push more for surgery or medical management, or?
So I definitely always offer medical management in cases where there is no polyp. When there is polyp, I definitely choose surgery. But when there is no polyp, I always try with medical therapy. If they receive already, let's say, a standard medical therapy and there was no improvement or worsening, then I would suggest surgery. But if that was not done before the referral, I would definitely try with medical therapy. And you can do also myringotomy. So sometimes you can collect the sample, but you can also clean the bulla, and sometimes it's also really helping them.
Cool. I think with Kun. I think you know him very well. You had dinner with him.
Yeah.
He was wondering whether practically you would have recommendation for when to assess efficacy of medical treatment and when it's not enough to recommend surgery. We kind of nearly brought that to some degree.
Yeah, it's hard. So now what I recommend is to look really clinically, because I'm not sure that if you redo an MRI, you will get any answer. If the case is doing fine, and if you redo an MRI, probably the MRI will show less severe lesions. But you cannot also think that even if the MRI is completely normal, that it will not relapse when you stop the therapy. So I think what we should try to find is the correct therapy for these cases, the length of therapy, that would be the most interesting. And then I would say if there is improvement, if there is improvement, I would not recommend to redo an MRI, definitely. But then if it's stable, you can always ask if you can redo the MRI after or before stopping the therapy. Because if you do it before and there is still otitis media-interna, probably you would go for surgery. If you don't do it and you stop the therapy, you don't know if there would be a worsening or not. But if it's normal, then in the MRI and you still get a cat with vestibular signs, probably it could be also just sequelae and not really active process that needs surgery. So I tend to more wait with the therapy, and if there is improvement or if it's stable, I just look after stopping the therapy if we should redo an MRI and go for surgery if there is a worsening. So it's really, for me, the clinic that is important in such cases.
Very good. There is no other question. As I say, Guillaume, to me, that's the kind of study I like. I like practical, clinical study which answer a question or challenge, practices that we've been doing, and so it's really up my street to some degree. Simon, I leave you the last word for this evening.
Yeah, just before I get to that, I have just one question just to clarify for the listeners. When you're talking about abnormal CSF, we have the protein assessment, the cell count assessment, and the cytology, and sometimes we can have normal cell counts, normal protein, but an abnormal cytologic cell distribution. What did specifically you look at there?
So we looked at the protein and the cell counts, and we looked also at the cytology. So I got results of cytology for all these cases generally, but there was some that were done just out of hours. So I cannot get the cytology for all the cases that we had, but the one that had abnormal CSF finding, meaning no increased cell counts, normal total protein, and then the cytology were looked, and it was also normal. I didn't get the cases with abnormal cytology alone from the results that I get. Yeah.
Great. Well, thanks for clarifying. And overall, thanks so much, Guillaume, for this great presentation.
Thanks to you for the invitation.
Again, no problem. It's our honor. We want to set this up so that the younger rising stars of the profession like yourself have a voice here for their publications and their studies. And you've been very brave coming on and discussing it and giving us your opinions, and you've done a great job. So we really want to thank you for that. Thanks also to everyone that's attended, and thanks to Hallmark Advanced Veterinary Imaging for sponsoring. The next journal club is on April the 5th, so coming up soon, and we're going to be talking about MRI and oligodendrogliomas. If you have a publication coming out soon, and it is on neuroimaging, then please get in touch with us if you'd like to be on this journal club. So thanks very much to everyone, and we will see you again soon.
Thank you. Bye.
Bye, everyone.